Thank you very much for the opportunity of being here, and I'm covering for Dr. McBride today, and I'll be speaking about the role of prostate radiotherapy for clinically localized prostate cancer. And I think, as we've just heard eloquently from the last speakers, there have been really changes, paradigm changes in surgical techniques and surgical approaches, from whole gland to partial gland, the impact that the robot has had in terms of not only the numbers, but the approaches that are being used in the future. And I think we could say really the same thing for the evolution of radiotherapy in the treatment of this disease. And for people who have been in the urology field here at Memorial Sloan Kettering, I've been here for a number of years, and I can say that in every 5 years there have been dramatic changes in the way we deliver radiotherapy. And I hope to just share that trend and evolution of what radiotherapy has has it transformed through the years in the treatment of this disease. Well, firstly, there have been substantial improvements in our ability to deliver specifically higher doses, really revolutionary changes in the accuracy of radiotherapy and the cure rates as well. And I highlight here some of the important developments that we've observed through the help of randomized trials in particular, which has really impacted greatly on how we manage prostate cancer. There's certainly a recognition that dose levels have to be in the, if we're treating with radiotherapy alone, at least near the 80 gray level. And only 15, 20 years ago, standard community practices would be still to use 70 gray, which we recognize is a totally suboptimal dose. Pioneering efforts here at our institution for the utilization of IMRT and IGRT to enhance accuracy and reduce the dose to normal tissues has not only improved tumor control outcomes, but also significantly reduce toxicity associated with radiotherapy. And then recognition of the importance of, as mentioned before, of adjunctive androgen deprivation therapy for intermediate risk disease based on 2 randomized trials demonstrating a survival benefit, and many trials now demonstrating, at least with conventional doses of radiation, long-term ADT up to 18, 24 months, or even 36 months in combination with external beam radiation for the high-risk disease, improving survival outcomes. Here are the randomized trials which have demonstrated the importance of higher radiation dose levels. And in these 5 trials, basically, the comparison was of a 10 gray spread between 78 and 70 gray in one of the first trials from MD Anderson, small number of patients. But once again, you look through all of these trials, it was about a 10 gray spread, and the PSA relapse-free survival outcomes at about 10 years was generally improved by about 15% improvements. And these were patients who generally had intermediate or high-risk disease, but in this particular trial, there was evidence of benefit even in the low-risk patients who we probably at this point really don't treat much nowadays, as was spoken about before. With higher radiation dose levels and using conventional modes of radiotherapy delivery, the tolerance was acceptable, but it was recognized that higher radiation dose levels were associated with a higher likelihood of toxicity, urinary or rectal-related toxicity, as been shown in not all of them, but a number of these aforementioned randomized trials. And so there were, in about 10 years ago, questions that were raised, and appropriate questions. Is dose escalation accomplished with 80 gray, which these trials have demonstrated to be important, sufficient or adequate for the eradication of localized prostate cancer? Are there more potent dose escalation strategies, especially as we concentrate on intermediate and, more importantly, high-risk patients who are deciding to be treated with radiotherapy? And how could we more reliably reduce treatment-related toxicities when using dose-escalated radiotherapy? And after the advent of these randomized trials, we recognize that if we want to achieve a higher likelihood of tumor control, we need to push the dose levels up, but at the same time, how could we manage the treatment-related toxicities or keep it to a minimum? And are there ways to improve the technologies to become even more accurate? I'll share with you the 15-year results of basically, we started giving 81 Gray about 20 years ago, in 1997, in fact. And when we've looked at our patients, and this is PSA relapse-free survival for low, intermediate, and high-risk patients, as shown here in these group of patients, and basically at 10 years, about 80%, 70, 65%, and about 50% of the patients. When we look at 15-year distant metastases-free survival in this group of patients as well, again, we could see about 95% developing distant mets in the low-risk group, as expected, about 15 or 17% at 10 years for the intermediate risk group, and about 30 or 35% in the higher risk group. When we collaborated with our urologic colleagues, and this was back when we just initiated three-dimensional radiotherapy, we tried to encourage the patients, and not all of them did agree to it, but undergo a biopsy at 2 to 3 years post-radiotherapy. And looking back at these results, the incidence of a positive biopsy was around 20 to 30%, despite the dose levels that were used. And more often in this group of patients, we were seeing high-risk patients. So I would say that for high-risk prostate cancer, using conventional radiotherapy, which is daily radiation delivered over a period of 9-10 weeks, about 30% of the patients had a positive biopsy. Looking across the board, low and intermediate and high risk, as we concentrate on the numbers, and I'll be talking about it later in the afternoon, but about a third of the patients had positive biopsies in the high-risk group, not receiving neoadjuvant hormonal therapy. It would appear that there was an improvement in tumor control outcomes when we use adjunctive hormonal therapy in conjunction with radiation, because it would appear to act as a radiosensitizer to enhance tumor control. So are there more potent dose escalation strategies, especially as we consider the patients who we are treating nowadays, and that is intermediate risk and high-risk patients? And this is a very important trial, a randomized trial, where patients with high risk or unfavorable intermediate risk were randomized to receive either external beam radiotherapy alone, with a boost, and so to bring the dose levels up to 78 Gray, which is the acceptable dose escalated levels that we use for clinically localized disease, or if we could intensify the radiation by utilizing a brachytherapy boost in combination with the external radiation. In this group of patients, all of them had hormonal therapy, since we were dealing with a higher risk cohort, for roughly about 1 year. And interestingly, and this is really the only randomized trial of its type comparing combination of external beam and brachytherapy versus external beam alone. And this combination was associated with, at close to 10 years, a significant PSA relapse-free survival benefit, here from 70% to 94%. Now, I don't consider this trial as a reflection of brachytherapy enhancement of the outcome. It's just purely, as I see it, a dose intensification effect. And it corroborates the notions we've had over the years that the higher the dose we can put into the gland, the greater the likelihood of tumor control, and likely the PSA relapse-free survival is a reflection of local tumor control and the advantage seen with enhanced dose intensification. Also, when we look just at the high-risk patients in particular, there was, again, about a 20% improvement in PSA outcome between this dose-intensified arm, which relied on brachytherapy combined with external beam, compared to external beam. Note that these differences were not noted really during the first 4 or 5 years. The curves begin to split after 5 years. And in that study, which is this Canadian trial, which was known as the ASCEND-RT trial, there was a higher degree of urinary side effects, higher than we observe in our own institutional experience. And this is grade 2 urinary, the combination 33% versus 21%. We see it actually in our own experience with this combination at about 15% grade 2 urinary symptoms requiring prolonged alpha blockers. Grade 3, 18% is far higher than really any other US experience or any published experience. This was quite surprising. We have 15-year data on this combination therapy where our urethral stricture rate is about 3 to 4%. And so a little bit surprising here. It could be and likely based on the technique. But again, highlights the fact that as you push dose levels, you need to be very cognizant of the normal tissue structures. When we've looked actually in one of our residents recently presented this at ASTRO, our society meeting, looking at patients who have about 20-year follow-up. And interestingly, for GI, late grade 3 toxicities observed in only 1% of the patients, no grade 4 toxicities seen. And this is in the group of patients we delivered 80 gray to with 3-dimensional IMRT. For urinary toxicities, late grade 3 and 4, these are basically the 3s are urethral strictures seen in 2% and grade 4 in 0.3%. And we recognize as well, and this is well documented, the median time to GI toxicities about 2.5 to 3 years, and median time to toxicity 5.5 years urinary. Interestingly, after 10 years, we didn't see an unusual uptick of toxicities, which is sort of I guess a notion, or maybe a mistaken notion that people have, that after 10 years significant toxicities develop. We fortunately are monitoring patients and are not observing any kind of very significant increases. And so where does that bring us now to in the last 5 and 7 years? Well, there's been an amazing efforts to try to get the radiation more accurate. And this has been accomplished with the placement of fiducial markers, where our urology colleagues have really been helpful in doing this. This is generally could be done under transrectal ultrasound guidance. The placement of these markers, which allow us to target the radiation on a daily basis so much more accurately. And we now have software developments where we can not only correct before they get or when they get on the machine, but during the actual 3 to 5 minutes of treatment, we can correct for any motion that's going on due to gaseous distension in the rectum or bladder filling to make for any corrections possible during the actual treatment delivery. And we are also, and really, I think one of the only institutions in the world where we have the fortunate availability of utilizing MRI-based mapping and planning. Radiotherapists throughout the world rely heavily upon CAT scanning to visualize, contour the prostate, map everything out. And now we don't rely anymore on a CAT scan. We will utilize in general, except for those patients who can't get an MRI, like those with pacemakers or the like. But use MRI contouring, where clearly we all recognize the ease of delineating the prostate, certainly much more than CT, and using planning as well based on the MR delineated images. Here I could show you here is how we could so much clearly see not only the apex and the base, but just the full anatomy. And in the past, we may have contoured the prostate all the way out to the obturator internus musculature, and now we don't really need to do that because we could see things so much more clearly. And this reminds me to let you know, and we've talked about this in the real-time OR presentation from yesterday, the placement of a rectal spacer, which dissolves after a few months, has really revolutionized our ability to limit the rectal dose. And this basically for us almost is a mile of space in radiotherapy language between the posterior aspect of the prostate and the anterior rectal wall. And this basically almost eliminates rectal dose. But we could see in the various planes helping us as well, and there's the rectal spacer there. These real improvements in terms of technology have also made a huge impact and changes in the way we deliver radiation. Conventionally fractionated radiation classically is radiation delivered daily, Monday through Friday for 10 weeks. And now what has emerged is really transforming the way radiotherapy practices around the world are managing their patients. In general, I'd say all around the world, shorter radiation courses with higher doses per fraction, which we recognize are biologically more advantageous for tumor control based on alpha-beta formula and those estimations of biologic equivalent dosing. And randomized trials have demonstrated no significant differences in the tumor control outcomes when we use, for instance, 5 weeks of treatment compared to 10 weeks of treatment. And here are 4 important trials that have been conducted. Now the follow-up is generally at about 5 or 6 years, and these have compared the conventionally fractionated radiation delivered in general over 10 weeks to a 5-week course. And these studies have looked at toxicity, and there haven't been dramatic differences between the shorter courses of 5 weeks compared to the longer courses. And when we look at tumor control outcomes, albeit the shorter follow-up of 5 years, and some of these trials were designed as non-inferiority trials, there were no significant differences in terms of tumor control or superiority for patients who were receiving the conventional, traditional 10 weeks. And I'd say in many places in the United States, at least right now, radiation oncologists have moved from 10 weeks of treatment to at least 5 weeks of treatment, which certainly is more convenient for the patients, and so far is not demonstrating any evidence that we are harming the patient, and actually it may in the long run end up being beneficial. But then there's been even a further move, and that is ultra-hypofractionation, where we move from 5 weeks down to about 1 week. And we have treated right now at our institution and our department getting close to about 800 patients with ultra-hypofractionated radiotherapy, where we're giving 5 fractions instead of 50 fractions, roughly. And single institution experiences have utilized these 5-fraction regimens, which dose ranges range from 35 to 40 gray. Generally, again, 5-year outcomes, so it's still early, 90% for low and intermediate risk patients, and no significant toxicity higher than what we observe with the conventionally fractionated treatment. We here finished a dose escalation trial, which we presented at the recent ASTRO meeting, and actually demonstrated that as we moved from 32.5 gray in 5 fractions, delivered basically over a week and a half, to 40 gray, one of these endpoints, a secondary endpoint, was the 2-year biopsy outcome. And the 2-year biopsy outcome in the cohort who received 40 gray was only 8% positive biopsy. You may recall we talked about 30, 35%, and these patients had basically intermediate risk disease And so it appears that these kinds of dose levels are very helpful in terms of, or efficacious in terms of tumor control. Unfortunately, and the only way that we're going to learn anything are through randomized trials. And these are randomized trials now ongoing, looking at intermediate or some low-risk disease, comparing the conventionally fractionated treatments or moderate fractionation of 5 weeks to these ultra-hypofractionated regimens where we are moving into just a week and a half of treatment. You may hear about on the radio CyberKnife or the like. That's just a machine that delivers hypofractionated radiotherapy, but really any sophisticated linear accelerator is able to do this. And so I think with MR-based contouring, we're able to really target the radiation much more accurately and more safely than ever before. So in conclusion, enhanced treatment delivery and planning techniques have resulted in improved outcomes for our patients with clinically localized disease. The critical ingredients for success are many, but the ones that we've highlighted this morning include dose escalation, the use of image-guided radiation as a more accurate way of treatment delivery, monitoring prostate motion during the actual treatment, and the use of hormonal therapy for intermediate and high-risk disease. And the integration of multiparametric MR imaging incorporated within our ability to deliver these intense doses to the dominant lesions, and hopefully in the future, as we have an ongoing open study right now, we will try almost like partial gland ablation to reduce the volume of the even normal parts of the prostate with its normal tissue structures such as the bladder neck and other areas like the nerve bundle, reduce dosing there, intensify dose to the dominant MR lesion, and hopefully further improve the quality of life for the patients we treat. Thank you very much.